And then Dr. Rohan, so the topics that you're going to cover today, is this accurate if I say this? So today's session will feature Dr. Darren Rohan from Northwell Health. He will discuss surgery methods and approaches. In addition, we'll cover what you will need to know before you or a loved one gets their surgery. Does that sound accurate?
Yes.
Okay.
Ty, are you ready? I'm ready to open up the lobby.
Yeah, let's wait just until the top of the hour.
Okay.
Yeah, it looks like we have a handful of people in the waiting room. Let's give them just a couple more seconds to start really filling up. Here they come. They're slowly approaching. Okay, Michelle, whenever you're ready, do a countdown and then you can open up the waiting room. And I'll do the intro.
Very good. 3, 2, 1.
Hello, I am Tyza here, National Director of Lung Cancer Education at the American Lung Association. And today I will be moderating our session. Welcome everyone to today's Lung Cancer Patient Meetup on the Go. Lung Cancer Surgical Intervention Options. I would like to acknowledge our sponsor, Northwell Health, for supporting lung cancer education programs like our session today. The session will feature Dr. Darren Rohan from Northwell Health. He will discuss surgery methods and approaches. In addition, we will cover what you will need to know before you or a loved one gets their surgery. Dr. Rohan is the Westchester Regional Director of Thoracic Surgery program for Northwell Health, treating patients at Lenox Hospital, Northern Westchester Hospital, and Phelps Hospital. He is a highly skilled leader in robotic thoracic surgery with expertise in robotic and minimally invasive thoracic procedures for lung surgery, hernias, gastroesophageal reflux disease, esophageal cancer, and mediastinal masses. At the forefront of innovation in robotic technology, Dr. Rohan has pioneered and has many groundbreaking accomplishments. He was the first thoracic surgeon in the country to use Da Vinci Xi robot for surgery, a robotic surgical system that allows for smaller incisions, enhanced flexibility, and pinpoint precision. He is also the first nation in the nation to perform a lung lobectomy with the Da Vinci Xi robotic system. Dr. Rohan identifies patients with lung cancer who might be a benefit to clinical trials. He is also working to develop new techniques and treatments for reflux disease. Dr. Rohan serves as assistant professor of cardiovascular and thoracic surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He is a member of various prestigious medical societies, including the Society of Thoracic Surgery, the New York Medical Society, and the American College of Surgeons. As we begin, please note that participants will be on mute. Participants may ask questions in the Ask Questions feature of the webinar platform. We'll have a brief question and answer session at the end after Dr. Rohan's presentation. At this time, it is our honor and privilege to have Dr. Rohan speak. Dr. Rohan, the floor is yours.
Thanks, Ty. Thanks for the introduction. Welcome. Good afternoon. I want to talk today about lung cancer surgery, and I'm going to focus mostly on treatment of early stage lung cancer and the advancements. We're going to describe the staging for lung cancer and the treatment guidelines, including the role of surgery in early stage lung cancer. We'll also talk about the tools we have for diagnosis and staging, and then talk about minimally invasive techniques that have been used over the past 10 to 15 years to really make lung cancer surgery more of a straightforward procedure and better tolerated for patients who unfortunately develop lung cancer. When we talk about lung cancer, unfortunately, it's the leading cause of cancer death for both men and women. In 2008, there were about 215,000 new cases of lung cancer, and approximately 161,000 people will die of lung cancer each year. So the expenses that we cost to treat lung cancer is exorbitant. In men, lung cancer is much more common to cause death than prostate cancer and colorectal cancer. And even in women, lung cancer deaths are more common than breast cancer and colorectal cancer. As a society, we've been screening for colorectal cancer and breast cancer for many years. Lung cancer screening is something that, as physicians, we've been pushing for and have begun to see that in the past 5 years. We now screen high-risk patients, those patients with a history of smoking in the past 15 years, between ages 55 and 77, that don't have any symptoms. They can get a low-dose CT scan to see if they have any evidence of lung cancer. We've done trials to show that by screening the right population, we can find lung cancers earlier, and the earlier we find lung cancers, the better we can treat them. If we find early stage lung cancers that are stage 1 or early stage 2, we can decrease the mortality of lung cancer just by screening. So, the population, there's approximately between 8 and 9 million patients who are considered high risk, and we can save approximately 12,000 lives a year just by doing lung cancer screening. So this society, the Society of Thoracic Surgeons has really pushed to screen for lung cancer, given the amount that we see. The benefits of screening is finding lung cancer early. There are some risks because when we do CAT scans for patients, there is a risk that we'll find other things or nodules that aren't cancer and give patients a risk of undergoing procedures that they wouldn't otherwise need. But now that we've been doing this for several years, we found that when we screen the correct patients, the benefits certainly outweigh the risk. Moving forward, I just wanted to show you what lung cancer can look like. So these are 2 CAT scans, and on the left, you can see this mass, which is probably about the size of a golf ball. This is a lung cancer. Now, despite the size of it and the location, most likely this patient would not have any symptoms, meaning this mass could grow for months or years before anybody would realize that there is a lung cancer. If you look over here, this finding is much more subtle, and this is usually how lung cancers start. Normal lung is this gray color on a CAT scan, and you can see the abnormality here, which is also a lung cancer. When we talk about lung cancer, it's important to understand the anatomy of the chest. So there's two lungs, the left lung and the right lung. The heart is in the middle, and it's between the left and the right lung, more leaning towards the left-hand side. On the left side, the lung is broken up into two lobes, the upper and the lower lobe. On the right-hand side, we have the upper lobe, the lower lobe, and also the middle lobe. Each of these lobes of the lung has its own blood supply and blood drainage. Also, the windpipe or the trachea goes down and breaks off into the left and right bronchus, and that's how air gets into the lung. So when we find lung cancers, more often than not, these cancers are in a specific lobe of the lung. Sometimes when they're larger, they can be in two of them, and when they're more central, they can affect more than one. But depending on the lobe the cancer is in, that kind of directs the surgery that we do. So again, this is just to better show the lobes of the lung on the left and the three lobes on the right. Now, going further down, when we look at the lungs, each lobe has segments that have their own blood supply. So the upper lobe of the right lung has several segments, and each lobe has different segments. And as we find lung cancers that are smaller, we can identify the segments that they're in. And sometimes, depending on the size of the lung cancer, instead of taking a lobe or a larger portion of lung, we can remove certain segments. And so overall, there's 10 segments on both the left and the right, divided between the lobes of the lung. The imaging that we do to see lung cancers, classically in the past, we've used a chest x-ray, and you can see a chest x-ray here. Now, when cancers and abnormalities are large in the chest, we can see that on the chest x-ray, and it's very clear. The problem is sometimes when these cancers are small or subsolid, a chest x-ray can miss it. And so in the past, we've done chest x-rays, and I'm sure patients have gone to doctors, and doctors have ordered chest x-rays. And patients can feel a false sense of security if the chest x-ray is negative. Certainly, there's no large cancers, but there still can be small cancers that are hiding. And so we've moved more towards the CAT scan of the chest, which this is a picture of. And with a CAT scan, you really get a good sense of what's going on within the lung. And if there are small abnormalities like this one here, we can find lung cancers early. So when we screen patients, we screen them with CAT scans and not chest x-rays. And a CAT scan will show a lung cancer if a lung cancer is there. So now, what do patients feel if they have lung cancer? And this is the problem. The first thing up here, asymptomatic. Most patients that have cancer of the lung that's early feel nothing. They don't have any weight loss, no cough, no shortness of breath. And so what happens is lung cancers can continue to grow and spread without anybody knowing it. When lung cancers get bigger and involve more central areas, patients can develop a cough, they can develop shortness of breath. Sometimes they can cough up blood. Sometimes they'll complain of chest pain or an infection. And then when the cancers really begin to spread, patients can have weight loss. So when we do CAT scans, what we can see are lung nodules, and those lung nodules can be lung cancer, but they can also be other things. Abnormalities in the lung can be due to infections, they can be due to bacteria, they can be due to fungal infections, they can be due to mycobacteria, which is the cause of tuberculosis. We also find inflammatory nodules. Sarcoidosis can cause nodules. Rheumatoid arthritis can cause nodules in the lung. You can find benign nodules like hamartomas or fibroid nodules that may be growths, but they're not malignant cancers. And then lung cancer, the classic lung cancer is divided into two types, the small cell lung cancer and the non-small cell lung cancer. In general, small cell lung cancer is a more aggressive type of cancer, and it's rarely found early, and it's rarely treated with surgery. Most commonly, we treat non-small cell lung cancer with surgery when it's caught early enough. So how do we diagnose lung cancer? Like I discussed, really the best way to diagnose lung cancer is to see an abnormality on a CAT scan. Once we see an abnormality on a CAT scan, we do other tests to confirm whether or not that is lung cancer. And the tests that we do, the next test that's normally done is what's called a PET scan. A PET scan is very similar to a CAT scan, except that it looks for increased activity within a lesion. So a patient is given a sugar solution in their veins, and it's looking for cells that pick up the sugar solution faster than other cells. And those cells would light up on a PET scan. And cancer can cause PET scans to light up. We can also have inflammatory problems that cause PET scans to light up. We can also see if lymph nodes are involved or if there's any evidence of spread. Once we know that we have something that's concerning, it's important that we do a tissue diagnosis to confirm that it is lung cancer and then to see what type of lung cancer it is. And so there's several ways to do diagnosis with tissue, a bronchoscopy where we put a camera down the windpipe and we can do biopsies that way. The second option is a needle biopsy, which is done with a CAT scan assistance. And a needle is placed on the outside, through the outside of the chest between the ribs to the nodule. We also have new technologies called navigation bronchoscopy, which gives us a GPS of the lungs and allows us to drive a bronchoscope virtually using virtual guidance into the lung and to get a diagnosis. So this is a picture of what we see when we get far enough out where we can't look. We can use the GPS bronchoscope to get to an area of concern and do a biopsy. This is called electromagnetic navigation bronchoscopy. It uses bronchoscopy and CAT scans as well as electromagnetic device to guide us where we need to go. So a patient would sit on electromagnetic field, and then the physician would do a normal bronchoscope, but would have all the extra information to guide the camera and guide the guide to a nodule or to a mass in order to make a diagnosis. So here you can see we're far out in the lung where we have an abnormality that we think is a lung cancer. Once we've driven there, we can use either a needle or a forceps to take a piece of the tissue, and we usually have a pathologist right next to us who takes that tissue and can tell us whether that's a cancer or not. We could use needles, we could use brushes, and we can use biopsy forceps. And this is all the way deep within the lung. So back to the anatomy, when we are talking about lung cancer, we need to know where in the lung it is. We also have to look at the lymph nodes associated with the lung to help us accurately stage the lung cancer. So lung cancer staging is based on where the lung cancer is, how big it is, if there are any lymph nodes involved, and where those lymph nodes are. So there's lymph nodes within the lung, which are called hilar lymph nodes. They're either on the left hand or the right hand side. And then there's lymph nodes in the middle of the chest, which are called mediastinal lymph nodes, and they go on either side of the trachea, under the trachea where it bifurcates to the left and the right, and even lower down. So that's how we stage a lung cancer. So there's specific stations that we use, and they're given numbers. So depending on where the lymph node is within the body, we'll give it a number. So an upper tracheal lymph node in the middle of the chest is numbered 2. A lower is numbered 4. Depending on the side, whether it's left or right, we'll give it an L or an R. And then once we get deeper into the lung tissue, those lymph nodes in the hilum are numbered 10, 11, and 12, and then left or right. There's lymph nodes that are between the aorta and the pulmonary artery within the chest. Those are labeled 5 and 6. So knowing the lymph node status and knowing the size of the cancer, we can start to figure out the stage. Now, staging is important because it determines the treatment of the lung cancer. Early stage lung cancers are treated with surgery. Later stage lung cancers are treated with other treatments and then possibly surgery. So the first thing we look at is the size, and that is the T stage. A T1 is less than 3 centimeters. A T2 is between 3 and 5 centimeters. T3 is between 5 and 7 centimeters, and T4 is 7 centimeters. The next thing we look at is whether any lymph nodes are involved. N0 is no evidence of lymph node involvement. N1 is when the lymph nodes within the hilum, within the lung itself, are involved. And those middle lymph nodes around the trachea, if they're involved, they're classified as N2 lymph nodes. And N3 lymph nodes are lymph nodes that are on the other side. Finally, we look to see if there's any evidence that the cancer has spread, and that's whether there's metastasis. M0 is no metastasis. M1 is evidence of metastasis. And once we know the T, N, and M, we can stage lung cancers. And the stage of the lung cancer is important because that's going to determine the optimal treatment. So a stage 1A, which is treated with surgery, is a 3 centimeter or smaller lung cancer that has no lymph nodes involved. And as the stages go higher, the cancers are larger, they're more close to the middle of the chest. And once we get to stage 2B and 3A, those are when lymph nodes are involved. Stage 3B is more advanced, and stage 4 is when it has moved to other areas besides the lung. For example, it can move to the brain, it can move to the liver, it can move to the bone, or it can move to fluid around the lung, and all those are stage 4 lung cancers. So early stage lung cancer, stage 1, the lymph nodes are negative, the tumors are small. Stage 2 would be a larger tumor, and you might have lymph nodes that are within the lung on that side, the hilar lymph nodes. Stage 3 has more diffuse lymph node involvement and a bigger tumor, and stage 4 has metastasis. So when we look to make sure how we stage patients correctly, we use CAT scans, we use the PET scan, and then we also use tissue to make sure we know exactly what lymph nodes are involved to accurately stage patients. So 2 ways to do that is with a mediastinoscopy, where we can actually put a camera outside the windpipe, and that way we go in and biopsy the lymph nodes to decide for sure whether these lymph nodes have cancer. And it's important to do that before we do any surgery, because if there's cancer involved, the studies show that getting chemotherapy or chemo and radiation therapy before surgery leads to a better survival. So we really do our best to make sure we know the stage accurately before we do the treatment. We can also use an ultrasound on the end of a bronchoscope to biopsy the lymph nodes. These ultrasounds can allow us to put a needle in the lymph node and get some tissue in order to see whether the lymph nodes are involved. And the ultrasound can allow us to biopsy deeper lymph nodes to truly get an accurate stage of what the patient has. You can see on this ultrasound, if you look closely, the needle is going into a lymph node, which is right here. And that way we know for sure whether that lymph node's involved with cancer or not. Sometimes we try to get a diagnosis, but for whatever reason, we don't get cells. You know, we do the best we can with the information that we have. So now let's kind of turn to really the crux of what I want to talk about, and that's surgery for lung cancer. And so when we talk about surgery for lung cancer, you know, there's several things that we take into consideration. Obviously, what I was talking about before, we take into consideration the stage. But we also need to look at how do we access the lung? Do we make a large incision? Do we make smaller incisions? And then we have to understand, once we get there, how much lung tissue do we take? And so those are really the main components of lung cancer surgery. But in general, the aim of surgery for lung cancer is to completely remove the tumor and all the associated lymphatic drainage. We want to go try to remove lung tissue without really touching the tumor at all. So we try not to cut into it or disturb it in any way. We want to remove whatever we have to in order to get the whole cancer out. In addition, we have to do it safely, limit postoperative complications, and then we need to make sure patients are strong enough that if they need treatment after surgery, they'll be strong enough to have it. So what are the indications for surgery for lung cancer? So in patients that have stage 1 lung cancer, where they have a 3 centimeter or less cancer and lymph nodes are negative, then the surgery is indicated to remove the cancer. And as long as it's less than 4 centimeters, it's surgery alone. No further treatment is necessary. For stage 2, we still recommend surgery as being the optimal treatment to treat stage 2 lung cancer, but then patients will be referred for treatment with chemotherapy after. When we're dealing with stage 3A cancers, we try to treat patients with either chemotherapy or chemotherapy and radiation first to try and shrink the cancer and treat the cancer before we remove it. And then any stage higher than that is usually not treated with surgery. The goal for surgery is to cure the patient, to get every amount of cancer that we can see out. And if we do that, we do have a chance of cure. So like I said, the extent of surgery, how much lung do we remove, is important. There are several amounts of tissue that we can remove. The smallest amount is called a wedge resection, where we just remove a piece of lung not associated with the anatomy that might contain the cancer. The next amount of tissue that we remove is the segmentectomy, where it's a portion of the lobe of the lung. So like I said in the beginning of the presentation, on the left-hand side, there's two lobes, an upper and a lower lobe. Each of those lobes has approximately 4 to 5 segments. So we can remove each individual segment or a combination of segments and leave more lung tissue. Lobectomy is classically what we used to do to treat lung cancer. So in the past, before we screened patients, if we found a lung cancer, we would remove the lobe. So that might mean removing a half or a third of the lung, depending on what side. And finally, pneumonectomy is removing the whole lung. And for central tumors or big tumors, sometimes removing the whole lung is really the only way to get all the cancer out. The second thing we look at is, how do we approach the surgery? How do we get there? So in the past, an open thoracotomy, which is where we make an incision on the patient's side, go between the ribs, we would spread the ribs, cut the muscle, and it would give us access to the chest. Now, in the past 15 years, we've been able to do more minimally invasive approaches, and we started with what's called a video-assisted thoracoscopy, where we had cameras and instruments. And that very quickly led to robotic assisted surgery, which now is the most, certainly one of the most common ways of lung cancer surgery over the past 10 years since I've been doing it. I think when I started, maybe 7% of all lung cancer surgeries were done with the robot. And I think now we're up to 60 to 70%. So in the past 10 years, it's becoming the most common way that lung cancer surgery is being conducted. And with removing a portion of the lung, we also have to remove the lymph nodes in the chest. And those are really the important aspects of surgery. So when we talk about the extent of surgery, lobectomy is the gold standard. So each lobe of the lung has its own blood supply. It's got its own artery, its own vein, and its own windpipe. And so when we remove that portion of the lung, we will specifically dissect each vessel to the lobe separately. And once we do that, we'll tie it off or cut it off and then divide it. And then we can remove that lobe as well as the lymph nodes around the lobe. So in this schematic, this is one of the arteries going to the lobe. There would be lymph nodes associated with this artery, and we would take those lymph nodes out as well and send them to the pathologist. Now, as we have found earlier lung cancers and smaller lung cancers, we are able to take less tissue, but still do an adequate job of getting all the cancer out. In addition, as we're operating on older patients, some of them don't tolerate having half their lung out, so we would take less in those patients. And then we still find large tumors that are in the middle of the lung that would require either removing 2 lobes or the whole lung. So what we found, and this was a study done by Dr. Ginsberg, it's now almost 30 years ago, he found that when you took less than a lobe, the survival wasn't as good. And so because of this study, we would take a lobe for any lung cancer. Now, the patients that they were seeing back then are different than what we're seeing now. The size of the tumors were much larger, and so taking a lobe was absolutely necessary in order to make sure you got all the cancer out. But now with lung cancer screening, I routinely see cancers that are 1 centimeter in size. I can get a good margin and all the lymph nodes I need to get out with and leave tissue in. And so the amount of lung tissue that we take out is changing as we move forward. So this is a more recent study, and this is just looking at stage 1 lung cancers. It's looking at lung cancers that are approximately 2 centimeters in size. And they said, well, do patients do better if you take out the lobectomy, like we knew they did in the past, or can we take out less tissue? And what we're finding more and more is that for patients that have small cancers that are peripheral, that are early stage, we can take out less lung tissue and leave them with more lung tissue. And what that does is it allows for the breathing to be better. It allows for patients to recover quicker. And then, unfortunately, it allows that if those patients develop another lung cancer, we can treat that with surgery. Going back to the lobectomy, it is still the standard of care for lung cancer. So most patients that are diagnosed with it, most surgeons will do a lobectomy. And you can see that what we need to do is take the artery, the vein, as well as the bronchus to that specific lobe, the lymph nodes as well. But I will tell you, and in my practice, for certain patients that have cancers that are less than 2 centimeters, we're doing what's called a sublobar resection, where we just do a segmentectomy or multiple segmentectomies, and we try to leave as much lung tissue as possible. So how do we approach surgery? The approach, how do we get there? The lung is deep to the ribs and the muscles of the chest wall. Up until about 15 years ago, the only way to get there was to make large incisions, to spread the ribs, and to cut the muscles. And that gave us excellent access to the chest, but it was a very difficult surgery for people to recover from. They had lots of pain, lots of risk of complications, pneumonia, things like that. And so a posterolateral thoracotomy is the classic chest incision that we used to make, where patients are put on their side and the incision goes below the scapula, and the ribs are open and spread. And if anybody had lung cancer surgery 15 or 20 years ago, that's usually the incision that was made. We've begun, we try to make smaller incisions, so we would do anterior thoracotomy or a limited thoracotomy. But about 15 years ago, we were able to start doing minimally invasive approaches, and that's the video-assisted and robotic surgery. So this is a patient, and you can see the line of where the incision would be. It's open surgery. We have to cut the muscles, spread the ribs. It's difficult to recover, and it's what we used about 15 years ago. Now, many surgeons do what's called a Vats approach, where it's Vats stands for video assisted thoracic surgery. We make small incisions and we can put instruments in. We have a camera with high definition visualization so that we can do the surgery but not spread the ribs or cut the muscles. The surgery is the same, whether we make a large incision or whether we use the small incision. We do the anatomic lobectomy with dissecting the lymph nodes. And when we don't cut the ribs or cut the muscles, usually once the specimen is dissected out, we'll put it in a bag, make the incision a little bit bigger, and pull it out so that we don't contaminate any of the chest wall. And so the idea of this surgery is it's done exactly the same way as we used to do it. However, we do it through smaller incisions. And so to do that, there's special instruments. These are longer instruments, similar to instruments that we used for open surgery, but they're developed specifically to do through small incisions. One of the keys that for lung surgery is what's called a surgical stapler. This device was originally made in Russia back in the 50s and the 60s. And what it does, and it's been improved over the years, but it goes across tissue and it staples on both sides, and then it's got something that cuts the tissue in between. So we can use this on the lung tissue. We can use this on the arteries and the veins. There's special staplers for each of them. And it's how we are able to cut lung tissue without having it leak air or leak blood or anything like that. And it's really key in lung cancer surgery. So the advantages of not doing an open thoracotomy: there's less pain, patients recover quicker, there's less inflammation, we leave a chest tube in shorter. A chest tube is a tube that we leave in for any lung surgery. And what it does is it drains any air, fluid, or blood so that that doesn't build up within the chest. And so that tube usually stays in for several days. And then we pull it out in the hospital before we send the patient home. There's a shorter length of stay, early return to full activity. And then if patients do require chemotherapy, they are able to get that more effectively if their surgery is tolerated better. So the survival depends on the stage. A stage 1A lung cancer, the 5-year survival is right now between 90% and 100%. But as the cancer stage goes up, the survival unfortunately goes down. And this is clear to us, and it's why we do everything we can to diagnose and find lung cancers earlier rather than later. And screening has certainly helped with that. Now, my focus is robotic assisted lobectomy, and it's done with the Da Vinci robot, the same robot that does now general surgeries, prostate surgery, hysterectomies. And so we use the same robot, but we use it in different areas. The advantages are, I can do the surgery and control the instruments and the camera much better. The instruments bend. They act as miniature hands, miniature wrists. So I describe patients that if we don't use the robot, it's like using instruments on the end of chopsticks versus the robot gives us much more ability to dissect out the lung, to find the lymph nodes, and remove the portion of the lung safely with, no, as minimal bleeding, as minimal discomfort as possible. So the surgery, there is a robot machine at the bedside with 4 arms. My assistant is at the bedside. They change the arms as needed. I will be sitting at the console, looking and controlling the arms with the hands in the console, and it's a 3D view. The visualization is unlike anything else. So as opposed to making a large incision, we're able to make 4 small incisions of 8 millimeters. We make a larger incision to allow us to get the lung out. And we also use carbon dioxide insufflation to be able to make sure the lung is not in our way. Patients are on their side on the table, and incisions go between the ribs. So the benefits, there's benefits to the surgeon as well as the patient. It's an easier surgery to perform. It's more comfortable for the surgeon, and we have the instrumentation that really helps. I tell patients, I am performing the surgery. The robot is essentially a $2 million instrument. So if we have the ability to use it, it's very helpful. Patients benefit. The incisions are smaller. There's less pain, less blood loss, a shorter hospital stay. We see less conversion to open surgery, and lower complication rates. When we did minimally invasive surgery before robotic surgery, occasionally we had to convert to the open surgery. And the robot has allowed us to do that less. And so it's helped our results. The outcomes, when we studied it, show that patients do well. The time, it doesn't take much longer. There's less blood loss. The amount of lymph nodes that we can remove is better. The mortality is minimal. And long-term, the survival is just as good as if we did it open or we did it without the robot. We can use the robot for multiple different types of surgery and other types of lung or cancer surgery, but it does give us an excellent visualization. Before I get to questions, I'm just going to give a quick, hopefully this will work, video of a surgery that we did. And this patient has a lung cancer in the middle lobe. So we're going to start with the CAT scan, and you'll get an idea of what I see. So this is the cancer itself. So it's pretty central. And again, that's just another view. So this is what we see when we use the robot. It's very clear. The middle lobe is right here. This is dissection of the vein to the middle lobe. You can see it's done very bloodless, very precise. This is a lymph node that we're removing associated with it. This is an artery going to the middle lobe, more of a lymph node that we're removing. So we're guiding the stapler in to allow us to cut between the 2 lobes. And so once we completely isolate the middle lobe, we're getting deeper lymph nodes here. We can cut the tumor you can see here, and we've cut the bronchus. And once we get the tumor out with the lung tissue, we put it in a bag and take it out of the chest cavity. And here we're taking a little bit more bronchial tissue to make sure our margins are negative. And all this is done with the robot. The visualization is really spectacular. Once we've done that, we're going to sew the bronchus together with the robot, and you can see our visualization is excellent. And once we sew it together, we tie the suture, and then you'll see that we're able to inflate the lung. Both the upper and the lower lung is inflated. No bleeding, no air leak. And once we're sure everything looks okay, we'll leave a small chest tube in, undock the robot, and here you can see preoperatively and postoperatively what the x-ray looks like. So hopefully you get a good idea of what the issues are with lung surgery, and how we decide who gets the surgery, how we decide the approach for the surgery, and also how we decide how much tissue is taken. Ty?
Thank you, Dr. Rahan, for such a very informative talk. I'm really impressed with how far lung cancer surgery has come, and really excited for the future. So this brings us to our Q&A session. We've had quite a few questions that came from the registration. So we're going to take that first and give participants a chance to put some questions in the chat. But we'll go ahead and start off with the first question. I am especially interested in indeterminate nodules and the decision to go or not go for surgery. So what are your thoughts on indeterminate nodules in surgery?
Sure. So, you know, one of the things that we see when we do CAT scans, or even if patients come because they fell and got a CAT scan of their chest, is we see nodules, and not every nodule is a lung cancer. So I would say the majority are indeterminate, and the decision as to what to do is based on several things. The most important thing is the size. As these nodules get bigger than a centimeter, we're more concerned that they're going to eventually become a cancer. But looking at a nodule, usually what I'll tell a patient is, if it's indeterminate, the most appropriate thing to do is to watch it. We would get a repeat CAT scan in 3 months to see if it changes. Obviously, if it gets bigger, it's more concerning. If it gets smaller, it's unlikely to be a lung cancer. But it's usually a discussion that I have with patients. And some patients are very concerned and they want to know what it is. Others would rather wait to see if it gets bigger. So really, indeterminate nodules, it depends on the specific nodule itself, how big it is, and how long has it been there, and is it growing? I think I lost you. Are you still there, Ty?
Well, we do have 2 questions in the chat. Do you hear me?
Okay.
Okay. So we have a question. Can segments in the same lobe be removed if, oops, excuse me, something just went on my screen here. Okay. Can segments in the same lobe be removed if they are not next to each other?
So they can be, but usually if we remove several segments, they would be next to each other. If let's say there are 2 concerning areas, one in the upper lobe and one in the lower lobe, you can remove segments that are not next to each other. But if we're just dealing with one lesion and we have to remove several segments, those segments would be next to each other.
Another question, can nodules be resected out with a navigational bronchoscopy?
So they can't be resected out with navigational bronchoscopy, but they can be biopsied. Now, one of the exciting things in the future is going to be, are we going to be able to treat or maybe burn or kill these nodules without surgery at all? And I think navigational bronchoscopy is something that's going to allow us to be able to do those local treatments in the future, where patients with early stage lung cancer may not even need surgery at all. But as of now, it's only useful to biopsy, not to remove.
Excellent. Ken has a question. Thoughts on stage 4 surgery versus radiation when further progression occurs?
So usually stage 4 surgery is limited to surgery that's palliative, meaning it's done to help patients have less symptoms. But there are certain situations where we can do surgery for patients who have stage 4 disease. So there is an occasion where somebody will present with a small lung nodule that turns out to be cancer, and then one single evidence of cancer in the brain. For those patients, if they're completely worked up, you can consider doing surgery for stage 4. But in general, we reserve surgery just for palliative to make patients more comfortable. The problem with doing surgery on stage 4 is the chance that you're really going to cure is low because the cancer's already spread.
Perfect. Looks like I'm back on now. Thank you so much for taking over for a brief moment there, Michelle. We've got a few more questions and a little bit more time to answer a few more questions here. Margaret says, I have heard that lung cancer was relatively rare until about the time of World War I. Is that true? And if so, do you have a theory as to why?
So yeah, I mean, certainly the incidence of lung cancer has increased over time, and when you look at it, you know, there is a hereditary component, but really the more important component is environmental. So smoking, and then the environment that we live in. You know, there's many patients who are exposed to asbestos, and just you know, the environment with industry does lead to an increased risk of lung cancer. So I think it's the environment that we live in that's changed that leads to the increased incidence.
Very good points there. The next question is, what is a good candidate for surgical recession? For stage 1A or stage 1B with advanced COPD in terms of there's FVC or FEV1?
Yeah, so what they're referring to is pulmonary function tests. And so whenever we consider patients for surgery, we have to do breathing tests. And the breathing tests are, you know, blowing air out or taking deep breaths to see how well the lungs function. And depending on their function, that will let me know whether they're good candidates to have a portion or all of their lung removed. So usually we look at percentages of what we expect. So once patients have less than 50% of what they should have, it makes the risk of surgery higher. And usually, just from a specific number standpoint, once it gets below 1 for the FVC or the FEV1, the risk is much higher. So we take that into consideration when deciding the best options, either surgery, no surgery, or the extent of surgery based on their breathing tests.
Thank you for that. Next question is, I have a diagnosis, stage 4 non-small cell lung cancer, primary sit left lung growing outward into my chest cavity, attached to my heart and chest wall. At initial diagnosis, I was told no surgery or radiation after standard chemo. I started a trial drug 4 years later. I'm still here. I've always wanted the main tumor removed. Do you ever go in and remove existing tumor? If not, why not? I feel like it may rear itself up and I don't know about it.
Yeah, so congratulations, 4 years later, and what you're referring to is these new treatments that we're seeing. So in the past, we used chemotherapy to treat advanced lung cancer, but as we have done more studies on lung cancer, there are targeted therapies for certain cancers. So once we get a diagnosis, we can send cancers to be sequenced to see if they have these specific genes that may benefit from either immunotherapy or targeted therapy. And when they do, sometimes they have excellent results. In general, the answer to the question is usually we don't do surgery stage 4. However, if you have a cancer that seems to be stable without any evidence of disease elsewhere, that's not growing and it's not involved in anything, you can do surgery. And we're seeing this more and more as the treatments get better and better. So the determination of whether it can be removed is how big it is and where exactly it's located compared to the important structures. But if somebody were to remove it, you would have to understand that it may not affect your survival at all. And you could have done just as well with it being there than being gone. And so most surgeons would be hesitant to do surgery in that situation.
Thank you, Dr. Rohand. I think that's all the time we have for today. If you can advance to the next slide and I can wrap up the meeting for us. So if you have any additional questions, please let us know. You can email me at timoorzahir, timor.zahir@lung.org. Next slide, please. We have a bounty of lung cancer resources on the lung.org website. This includes the recordings of the Meetup on the Go and previous sessions. We offer mentorship, online support communities. We also offer a helpline and up-to-date information on lung cancer, as well as COVID information, which are all shown here on this slide. You can go ahead and take a snapshot of that QR code to gain access. It's all open access. We will provide information on this session, including the recording and answers that we couldn't get to over email. So be on the lookout for that. And your feedback is very important to us to help us continue to grow this program. We will also send out a feedback survey as well. So please give us your feedback. And with that, ends our session for today. Thank you, Dr. Rohan, for a great session on lung cancer surgery.
Thanks, Ty, for setting it up. I appreciate it.
All right, take care, everybody. Have a great weekend.